First of all, I would like to thank Dr. Shah for the opportunity to be here this morning. You already got a glimpse of some of the new things that are coming up in myeloma from Dr. Libby's talk. What I would like to focus on, these are my disclosures. What I would like to focus on today is the entire spectrum of the disease, starting from diagnosis to some of the more exciting therapies that are coming through the clinical trials. I'll start off with a patient scenario. So here's a 71-year-old gentleman who was noted to have elevated total protein level. The initial lab workup showed a hemoglobin of 13.7, creatinine of 1, normal calcium, serum protein electrophoresis. He had an IgG kappa monoclonal protein of 1.2, and serum kappa FLC and lambda FLC are normal. 24 urine protein electrophoresis shows an elevated total protein without any monoclonal protein, and a metastatic bone survey was normal. So which of the following would be an appropriate next step? Since we don't have the audience response system working, I think I just colored them in the correct answers here. So I think it's very important as we see patients in the clinic with a monoclonal protein to correctly categorize them as whether they have a monoclonal gammopathy of undetermined significance or smoldering multiple myeloma or active myeloma that requires therapy. Because it's patients with monoclonal gammopathy, they have a very low risk of progressing to symptomatic disease, and it's important for us to reassure them about this aspect of the disease. But at the same time, it's important to reiterate that these patients need to be followed up long-term, indefinitely. Because there's always going to be a risk of progression. So when you look at all the monoclonal gammopathies, it's a spectrum of disorders. On one extreme, there's the monoclonal gammopathy of undetermined significance, and on the other side, there's active multiple myeloma. And there are some patients in between whom we term as a smoldering multiple myeloma. Now, what distinguishes between these three stages is the increasing tumor burden, and when patients have end organ damage, they clearly have symptomatic disease. Now, more recently, the International Myeloma Working Group updated the diagnostic criteria for multiple myeloma. So on the left-hand side, you can see the classical definition of the CRAP features, which we are all very familiar with. And on the right-hand side is the expanded definition that was brought in through the revised criteria. Now, the reason why that the criteria was revised was these three biomarkers or myeloma-defining events predicted for development of CRAP features in a very short time frame. So 80% of patients who had one of these criteria had an 80% had a risk of developing symptomatic disease within the next 2 years. Now, this shows the current definition of multiple myeloma. So the hypercalcemia, the renal insufficiency, anemia, and the bone lesion stays the way it was before, with the only addition here being that creatinine clearance is now included within the definition of renal involvement. And then the biomarkers of early progression, as we just talked about. Now, that leaves us with a slightly modified definition of monoclonal gammopathy of undetermined significance, and especially smoldering multiple myeloma. So again, as we had previously defined, the serum monoclonal protein less than 3, less than 10% bone marrow plasma cells, and the urine monoclonal protein that's less than 500 milligrams per 24 hours defines SMUG as in the absence of any myeloma-defining events. Now, in the smoldering multiple myeloma, again, very similar characteristics as before, except the bone marrow plasma cell percentage now has an upper limit. Previously, it used to be anything that's over 10%. Now, 10 to 60% defines smoldering, because if you're 60% or more, those patients actually have myeloma that requires therapy. Now, not only has the definition of the disease changed, there have been some improvements in terms of how we assess the disease. Now, for the longest time, we relied entirely on the paraprotein measurement in the serum or the urine, or measurement of the bone marrow plasma cell percentage in the bone marrow by immunohistochemistry. Now, we know that even with the most stringent definition under the old criteria, which is the stringent complete response, the patients still continue to relapse. And we know that these patients still have a significant amount of disease that we are not detecting by these conventional methods of disease assessment. Now we have more sensitive tools to look for very small amounts of disease in these patients, and like other malignancies, especially hematological cancers, now we can actually assess minimal residual disease in these patients. Now there are several different methods that have been described. The ASO PCR has been around for a long time. The multi-parameter flow cytometry has been around for a long time as well, but there has been significant improvement in the technique or refinements of multi-parameter flow cytometry that allows us today to detect anywhere between 1 in 100,000 to 1 in a million myeloma cell from the bone marrow. And then the next generation sequencing approaches again has given us a better tool to look for in a very sensitive fashion to see if there are residual myeloma cells in the bone marrow of a given patient. I won't go into the details of the pros and cons of these different techniques. Suffice to say that we do have technology that allows us to detect small amounts of cells. Now this is the results of a meta-analysis that was done recently looking at the impact of minimal residual disease assessment. So on the left-hand side, you can see that patients who have a MRD negative status has a significantly better progression-free survival compared to patients who don't have MRD negative status. And the same thing holds true for overall survival as well. So, and if you look specifically in patients with complete response, again, you can see that within those subgroup of patients with a complete response, getting to MRD negative state do define a better progression-free survival and better overall survival. So these data led to the identification of the improvement in the response criteria. So the current IMWG response criteria now includes definition of an MRD negative state, and they can be either a flow-based MRD negative or sequencing-based MRD negative. In addition, we also defined an imaging plus MRD negative state where we have someone whose PET scan is negative in addition to the bone marrow being negative for MRD. And in addition, we have defined a sustained MRD negative state, which means that these patients have MRD negative which have persisted for a period of time, and we know that persistent deep response typically translates to better outcome. So how does, so that helps us identify how, diagnose the patients better and also assess the response to the treatments better. Now what about the treatments themselves? And as you already heard from Dr. Libby, significant advances have been made in terms of how we treat these patients. And I'll try and skip through some of the slides as you have already heard how we typically approach these patients with the initial therapy. When you look at the treatment paradigm, again, the first step is the accurate diagnosis and the risk stratification of these patients. And then we treat them differently based on whether these patients are eligible to undergo a stem cell transplant or not. And in the goal being to get the tumor burden to the least amount possible. So let's take a look at another patient here. So 67-year-old with a diagnosis of myeloma, has a M-spike IgG kappa of 3.1 gram per deciliter, and LDH of elevated at 314, beta-2 microglobulin of 7.1, albumin of 3.4, normal creatinine, slightly elevated calcium. And you do the bone marrow biopsy at 70% plasma cells with the 1114 translocation and deletion 17p. So which of the following treatment regimens will be a reasonable choice for this initial therapy? Now we already talked about, we already heard from Dr. Libby that the combination of bortezomib, lenalidomide, dexamethasone is the most commonly used initial therapy in patients with multiple myeloma, at least in the US. Now the reason why we do that is based on the SWOG 777 trial, again showing that addition of bortezomib to lenalidomide, dexamethasone actually improved the overall survival of these patients by roughly about a year. So clearly that allows us to use this combination. Now the question is, how do we make these combinations even better? So there is some data from phase 2 studies switching the bortezomib to Carfilzomib, which is a newer proteasome inhibitor. Now as you can see here, in patients who were newly diagnosed myeloma treated with Carfilzomib, lenalidomide, dexamethasone, you can see that a vast majority of these patients, 62% of these patients, can get a stringent complete response after 12 cycles of this combination. So really exciting data with respect to this, this new agent. Now, how else can we improve it? We could use a different oral proteasome inhibitor that is oral. And we heard from Dr. Libby the convenience of having something that is given orally. And with this, again, with the PI-IMiD combination using the oral proteasome inhibitor, you can see that the vast majority of patients get a response. And as they stay on therapy for prolonged periods of time, you can also see a deepening response in these patients. So obviously, these are very exciting phase 2 trials, but the practice has to be driven by randomized clinical trials. So there is this ICAHO trial, the EVEN-11 trial, that is currently looking at a comparison of Carfilzomib Lendex versus Bortezomib Lendex. And this trial is trying to answer two important questions. Is there a difference between these two different combinations, and whether an indefinite lenalidomide maintenance has any additional advantage over giving maintenance for a limited duration of time? Now, can we make them even better? So there are some very early data adding monoclonal antibodies to the Carfilzomib Lendex combination. This is from ASCO this year, again showing that you can continue, this combination can be given safely, and you do see nice deep responses among these patients. Obviously, this is very early on, so I don't think we are ready to change to this one, but clearly provides the data for future clinical trials. When you look at the toxicities, again very similar to what we have seen in the combination with Carfilzomib Lendex, and the addition of the monoclonal antibodies did not significantly enhance the toxicity of this triplet. Now similarly, I'm going to skip through this. Bortezomib Lendex, which is the current standard, Elotuzumab has been added to that combination, again showing good responses and reasonable toxicity profile. But I think the key is going to be defining the toxicity of these regimens in the context of a phase 3 trial before we actually move on to using this in the clinic. Now, once we have that initial therapy or the injection therapy, the next step is to use the autologous stem cell transplant. And the question has been raised as to whether it makes any sense to use stem cell transplant in the era of effective therapies. And this is data from the French trial that you already seen, that addition of stem cell transplant to the VRD injection significantly improves the progression-free survival. Now, additional questions have been brought up as to whether in patients who get one stem cell transplant, is there a role in giving an additional stem cell transplant or a tandem autologous stem cell transplant, or is there a role for doing additional consolidation therapy and maintenance therapy? Now, this is the STAMINA trial, the BMT-CTN trial, which randomized patients after one transplant to len maintenance alone, additional consolidation with the VRD regimen, or an additional transplant with MEL200. The data shows that there is no difference in the progression-free survival by doing additional therapy with consolidation or a tandem stem cell transplant, and there is no difference in the overall survival either, at least at the early data point. Now, in contrast, the Europeans did a trial where they did VCD injection therapy, 1 or 2 transplants, consolidation with VRD, and then maintenance. But they were actually able to show that the double stem cell transplant did improve the outcomes of these patients, particularly the patients with high-risk abnormalities such as deletion 17p and 414. And they also were able to show that the VRD consolidation did improve the PFS in those patients. So why are the results different between these two trials? Obviously, there are a lot of differences in terms of the trial design. One of the key differences is these patients got a VCD injection therapy, and the consolidation was introducing a new agent, which is the IMID in this setting. And then the transplant comparator was with VMP regimen, which also is different than what was used. But I think it's reasonable for us to say that in the current practice that we do, where VRD is the initial injection therapy, doing a single stem cell transplant and going on to maintenance it should be considered the standard of care. So what is the data supporting the use of len maintenance? Here's the meta-analysis of 3 different trials, again demonstrating that addition of lenalidomide maintenance clearly improved the overall survival of these patients, supporting the use of maintenance therapy in this setting. But one thing that you need to keep in mind is, again, there are groups of patients with high-risk myeloma where lenalidomide maintenance does not help, and those patients should be considered for a bortezomib-based maintenance therapy. Now, what about patients who are not eligible to undergo a stem cell transplant? These patients can be considered for lenalidomide dexamethasone, again based on this clinical trial comparing that to melphalan prednisone thalidomide, showing that there's an improved overall survival and PFS when you do RD compared to MPT. The VISTA trial looked at VMP versus MP, again showing that there's an improvement in the overall survival by adding bortezomib to MP. So another regimen to consider and commonly used in Europe. But I think in the US, the shift has been moving away from using melphalan-based regimens. And I think the trials like the first trial, which demonstrated an improved survival for RD, clearly supports the use of that regimen. Now, you heard from Dr. Libby that we can also use the combination like bortezomib lendex, maybe with some dose modifications in the older patients to make it more easily tolerated. Now, in terms of management of relapse, what I'm going to do is, for the sake of time, skip through some of these slides, since you already heard from Dr. Libby how you would use the different combinations in terms of sequencing the therapies in these patients. So I just want to highlight a few basic principles as to how you want to guide the therapy in these relapse patients. We know that patients get progressively become more and more resistant to therapies, and we know the genetic basis of that development of resistance, and that is the clonal evolution that happens in these patients. Now, this is old data now, but again showing that the clone that these patients finally die of are all usually present at the time of diagnosis, but often in very small numbers. I can show it to the pointer here, but you can probably not appreciate from the distance that there is actually a sliver of that blue even in the start. But as we give multiple different therapies, these clones ebb and come back, and eventually one of them becomes the most aggressive clone. Now, we already heard about the bortezomib lendex-based regimens. I just want to highlight the results of one of the studies that we did, where we look at patients who have relapsed after multiple therapies. And as you can see here, when you look at patients in whom you have, again, these are patients who have been refractory to bortezomib and lenalidomide containing regimens, or have been exposed to them before. And when you use regimens that contain different drugs, even though they are from the same class, these patients get a better outcome compared to when you reuse the same drugs. And we also know from the phase 3 trials that if you actually use a different drug class, such as a monoclonal antibody, you actually get a much better outcome than if you repeat the same class of drugs. So keep in mind, when you have patients with relapsed multiple myeloma, you want to try and introduce a different drug than what they have been exposed to, preferably from a different class. And you also want to try and use a combination, a triplet if you can. You already heard the data from Daratumumab, clearly very exciting introduction to the field. Now we have a monoclonal antibody, actually have 2 monoclonal antibodies that we can use in patients with relapsed disease. Now again, there are several different combinations that are being considered in the context of relapsed disease. Again, we are looking at combinations that are non-overlapping with what has been used in the initial setting. So if you're using bortezomib lendex as your primary therapy, you want to use something which is different. So you want to use either a different proteasome inhibitor, you want to use a different IMiD, or you want to use a monoclonal antibody. So one combination like that would be Carfilzomib-Pomalidomide dexamethasone, very good response rate in a group of patients who have seen a multitude of different therapies in the past. Similarly, Daratumumab-Pomalidomide dexamethasone. Now this regimen is now approved by FDA based on the phase 2 trials. Again, showing an overall response rate of 71% in patients who are refractory, many of whom are refractory to bortezomib and lenalidomide. So clearly a significant improvement in the field. Now, Isatuximab is a different monoclonal antibody that has been introduced. Again, the same target as Daratumumab, and the data with the combinations again appear to be quite promising. I'm just going to skip through this and talk about a couple of very new and exciting drugs that are going through clinical trials right now. So selinexor is a totally new class of drug that has not been used in myeloma before. It belongs to what we call a nuclear export protein inhibitors or SINEs, and this is the first one to be introduced into the clinic. Now, the initial data that has been presented at ASH last year, again, you can look at a group of patients who are refractory to, again, quad refractory, meaning len, pom, bortezomib, and carfilzomib. We know that the median overall survival of patients who are quad refractory tends to be very poor. And here you can see that these patients actually have about a 20% response rate by using a single agent selinexor. So clearly quite exciting in terms of new options, but we also need to take into account the potential for toxicity with these new drugs. So there are several phase 3 trials that are being planned looking at selinexor combinations, so stay tuned for those results. Now, another drug which has been quite exciting in this field has been Venetoclax. Now, many of you treating patients with CLL have been used to this drug. It's a very selective BCL2 inhibitor, and the BCL2 family protein has a significant role in the myeloma biology. Most of the myeloma cells tend to express high levels of BCL2, but also high levels of MCL1 in a subgroup of these patients. So what we have found with the single-agent Venetoclax in patients with relapsed myeloma, and again, this is a group of patients with a median of 5 prior lines of therapy. About 70% of these patients are refractory to bortezomib and lenalidomide and has had a stem cell transplant. The overall response rate was about 21% in this group of patients. But interestingly, when you look at the subgroup of patients with the translocation 11-14, the overall response was 40% in that group of patients. And you can also see the time to progression was significantly better among the patients who were translocation 11-14. Now, there have been other studies being done in that context trying to identify specific biomarkers. So if we can look at the BCL2 to BCL-XL ratio in these patient plasma cells, we can identify a subgroup of patients where the response rate could be as high as 90%. So clearly very exciting because of the existence of the biomarker. Now, you already heard a lot about the checkpoint inhibitors in the context of solid tumors. Pembrolizumab has been studied in the combination with both lenalidomide and pomalidomide in the relapse setting. And this is the data from Ashraf Bedrosh, again showing that a high response rate in patients who are refractory to many of these drugs. And when you use a combination of pembrolizumab with an immunomodulatory drug, you can actually get meaningful responses, again with a median duration of response of roughly about 14 months. Now, a note of caution with the immunomodulatory combination, the phase 3 trials that were looking at the len combination and the pomalidomide combination both have been held or actually terminated because of an increased rate of death in the group of patients getting pembrolizumab combinations. We don't quite understand what is the reason for death. We suspect that this is related to toxicities, which we all know has to be managed very differently when the patients are on checkpoint inhibitors. So I think one of the most exciting things with myeloma has been the development of CAR T-cell approaches. There are several CAR T-cell constructs that are currently going through clinical trials. And I won't go into the details of the approach as you understand the concept behind it. Now, this is the data with using a BCMA-directed CAR T-cell. Now, BCMA, or the B-cell maturation antigen, is uniformly present on plasma cells and is fairly uniquely restricted to them. And you can see an example of a patient on the left-hand side, a PET scan showing diffuse lesions, and on the right-hand side, 2 weeks after the CAR T-cell infusion, you see a PET scan that's almost near normal. And when you look at the bone marrow, you can see a complete clearance of the plasma cells in this particular patient. And the BB2121 is, again, a BCMA-based CAR T-cell construct that we have been studying along with other groups. And we have seen very good responses in these patients, and many of these responses have been durable, with the longest lasting being just about a year now. And there are several clinical trials that are ongoing right now with several companies coming into the field with different CAR T-cell constructs. Now, I just want to mention briefly the important role of supportive care. Now, Denosumab, as most of you are know about this, is a rank ligand inhibitor, and this was studied head-to-head with zoledronic acid in a large phase 3 trial. And this is data from ASCO this year, again showing that addition of using denosumab instead of zoledronic acid leads to the same outcome in terms of the incidence of skeletal-related events. So they're comparable. So now you have something that you can give subcutaneously instead of an IV infusion. What was intriguing in this, at least the initial data analysis, was the improved progression-free survival that was seen with denosumab compared to zoledronic acid. Now, we don't know whether this difference is going to stay or be sustained as we have more mature data. So I'll stop there, and I think we'll do all the questions at the end. Thank you.